Hey there, everyone. This is Dr. Sullivan back with you with another I Care for Your Brain live mini lecture. We've been doing these since October, every Wednesday night at 6 o'clock, and the purpose is to bring you high quality brain health information that will make you feel educated and empowered and very, very in control of this very important part of your life. And the reason I do this is because I'm concerned that you are not getting enough high quality, trusted sources of information brought directly to you, and that leaves you vulnerable to marketers who would like you to think that their quick fixes work, when in fact most brain scientists know that they don't work at all, and what you really need is what we call psychoeducation to inform you on how to make better choices. So that's really why I'm here with you today. We are going to be talking about something that is very important tonight, which is making the very difficult decision to stop driving and how to have that conversation with someone that you love. If you are affected by memory loss or you love someone who has been diagnosed with dementia, you know that there's a lot of important decisions that you have to make all along the care journey. But driving is probably one of the most difficult, and this is either to stop driving or to limit driving. And it's really hard because you're trying to balance two different things. On one hand, we really want to respect the independence and the freedom of the individual, but we really do have to balance that with ensuring personal and public safety. So that's why it's a hard conversation, because we have two competing issues that we are trying to satisfy. How do we keep the person and the public safe, but how do we take away something that so many people rely on for their identity, for a very strong sense of independence, especially in developed countries and Western societies? This is just so important to us as a symbol of freedom and autonomy. This is such an important topic to come at you from a neuropsychologist, because one of the things we can never do with brain health topics, and especially when we're talking about people living with brain health challenges, is to reduce our conversations down to just medical jargon. These things that we are talking about are, yes, involving an organ called the brain, but they are happening to social beings who are complex psychologically. They are spiritual beings. They are connected to other people in the world. They have a very rich life history. And what I really worry about, what really breaks my heart, is that people are being told, you're going to stop driving starting today, with no conversation, no collaboration, which is the key word for our conversation today that I want you to understand. How is it that we can have a respectful conversation that when the person is able, and there are times in dementia where the person is not able, but when they are able to have insight and awareness into what is changing, how is it that we can bring them into the decision-making process and not simply be taking away driving as yet another loss that goes along with having dementia? So part of why we're doing this is because I know for a fact that there are people out there that walk into their doctor's appointments and are told in a 10-second command, not a conversation, a command, that you will stop driving, you are done driving, you are no longer driving. And to me, that's very psychologically hurtful. And I know that that has to happen sometimes, and there are some instances where we do have to kind of override the person, mostly because they might not have the insight or awareness that they have a significant brain disorder like dementia. But all too often, it is yet another way that we objectify people with dementia, which is to treat them as non-people. And this is such an important topic to me, and such a foundation of the type of neuropsychologist that I try to be, which is to really never ever forget the humanity that is behind a dementia diagnosis. So, you know, this is especially relevant to the older folks that are experiencing dementia right now, because these are the people that when they were coming up in the 20s, the 30s, and the 40s, having an automobile was a super, super big deal. It was a sign that you had some financial success. There were songs written about you getting out in your car and bringing your girl to the high school dance. It just was a big part of culture, and it was a huge symbol of independence and freedom. So we have to always keep the psychological in mind when we're having this conversation. So here's what we're going to talk about tonight. We got to talk about what exactly is going on out there in the road. What are some statistics that will help us understand what are the risks specifically that are posed by people who have dementia and driving. I want you to know tonight that having a diagnosis of dementia does not automatically equate into no driving. There is a spectrum of choices between the way someone has always driven versus taking away their license. There are things called restrictions, and we need to talk about what those are. I want you to understand that there is a gold standard assessment for driving, and that is an on-road driving evaluation, and I'm going to tell you exactly how that works and how you can go about getting one. We also want to look to other families. What has worked? How have these conversations failed? And how have they been successful? And then I want to end by telling you about my 2 secret weapons that I pull out in my neuropsychology feedbacks when I need to have this difficult conversation with folks and it's getting a little bit tense and there's some sensitivity going on there. I have 2 things that I pull out as my last resort that I want you guys to know all about. So individuals who have moderate to severe dementia are 3 to 5 times more likely to get into trouble on the road. And specifically what the research tells us is that what is involved is car accidents, getting lost, not wearing a seatbelt, traveling too slowly. We sometimes think of driving too fast as the biggest risk, but in fact, driving too slowly is just as risky. We also know that, unfortunately, these folks have trouble obeying the rules of the road, being able to change positions when they need to move from one lane to the other. Stopping the vehicle smoothly has been shown to be difficult as you have advancing dementia. And interestingly enough, the most unique thing that I came across in my literature search for our time together tonight was that simply driving straight is a challenge in dementia. Now, this is, again, one of those things that when your brain is healthy, you don't even think about it. You just are able to go straight. It becomes very automatic, very unconscious. But there's actually a lot of starting and stopping and self-correction that happens within the brain to actually keep us on that straight path. And it seems that that is something that can go awry in moderate to severe dementia. Now, all brain scientists would agree with you that at the point of moderate to severe dementia, the person does need to stop driving for their own safety, for public safety. But we have no consensus about what to do with mild stage dementia or something called mild cognitive impairment, which is where someone has a cognitive symptom that is worse than we would expect just for their age, but it has not yet begun to impact their everyday functioning. They're still independent, they still drive without issue, remember to take their medications, and manage complex finances. That is mild cognitive impairment. There are no one-size-fits-all standard recommendations when it comes to making driving decisions. And this is why it gets very tricky, because we can kind of have extreme reactions on both sides, right? On one side, we can have people, doctors, that think the second you get diagnosed with dementia, which God willing, and thank God, is happening earlier and earlier, because we try to work so hard to emphasize to people how important it is to get diagnosed early, because the memory medications on the market today work to slow down the progression of the symptoms, and it makes sense. The earlier you take them, the more you're going to get a longer period of the highest quality of life possible. So people can actually get diagnosed with dementia very, very early. So there's some folks over here that say the second you get that diagnosis, that's it, hand over the keys. On the other hand, we also have people who are afraid to have this conversation with people, and doctors who actively avoid it. And what happens then is caregivers, family members, become the bad guy because they are the ones bringing it up. So we have to figure out ways that we can be helpful, respectful, compassionate, face this conversation. So the question becomes, well, how do we do that? Well, I wanted to tell you a little bit about how other people do it before we talk about kind of best practices. What the research was telling me when I was looking at it over the weekend is that we kind of have a continuum of family dynamics. And you can kind of think of them as either end of two spectrum. Over on this side, we have the we are in it together approach, collaborative, trying to be open, communicative, respectful. And on the other end, we have the at odds approach, which of course is a lot of conflict, significant tension within the interaction. And between those two things, we have two other ones called the behind the scenes approach and active negotiation. So of course, the thing I don't want for you is the at odds. And when this conversation becomes the most painful is when people are butting heads like this. So we really want to try to figure out, when is it that we should be having this conversation? What are some communication skills that we can bring to the conversation that will make it go more smoothly? What words are we actually supposed to use? What is our supporting arguments to help the person see things through our eyes? So let's just talk about when to actually be concerned. So one thing that is hard in dementia that we have to talk about is a symptom called anosognosia. And what this means is that the person has a neurological, a biological inability to have insight and awareness into their own deficits. It's not that they're being defensive. It's not that they don't want to see what they're losing. They literally don't see it. And this happens more in some subtypes of dementia than others. Alzheimer's disease is the perfect example. The person really does not see it the way you might see it. And some people, in fact, call this the blessing of Alzheimer's disease. And it doesn't happen as a first symptom. It's more in the moderate to severe stage. And of course, it's not for everyone because some people are painfully aware of their decline. But the truth is that this symptom really matters when we talk about driving, because if you don't have insight and awareness, it's really hard because the person simply does not see your concern. They don't get it. They don't see what they're doing wrong. So when that is happening, we have to get creative and go to some other techniques to make sure that we are ultimately keeping people safe. And you know, I have so many conversations with people in my practice about care and how is it that we can do our very best when people need us the most during a diagnosis like dementia. And the first thing on your pyramid has to be safety. It has to be their safety, your safety, and under that comes well-being. And this might be one of those conversations where ultimately you have to do something like lose the keys, cut off the starter to the car, get creative about where is the car, it's in the shop. There's all these different things that you might have to do because the first priority has to be safety. So what I want you to be a good observer of, if you are starting to become worried, is we have high-risk behaviors and we have warning signs. So within high-risk behaviors, this means once something scary, concerning has happened, it's much more likely to happen again. So of course, getting lost is a big one, right? A car accident, getting a ticket, having a near miss. But the warning signs are much, much more common. So the high-risk behaviors actually happen after there's been warning signs for quite some time. So the warning signs are probably more where you really want to pay attention. So this is difficulty parking. Parking actually takes a lot of cognitive ability in terms of visuospatial skills, problem solving, fine motor speed, reaction time. There's a lot of things that go into it. Being aggressive behind the wheel, misinterpreting things that are happening on the road. Someone in my family who we later realized was having some problems, not only with dementia, but also glaucoma, which is very important. We can never forget that people with dementia don't suddenly lose their right to have other medical issues that may also be impacting on driving. But when we would be in the car with him, he thought that everybody who had their headlights on was flashing their brights at him, and he would actually become very aggressive and agitated. And so when you see misinterpretations of what other people are doing to them, that's a time to become concerned. Riding the brake, being almost overly cautious because maybe even unconsciously there is a sense that this is a dangerous, scary situation. Inspecting the car will actually get you far. Looking to see if there's dings, especially if you have a garage. That takes a lot of brain ability to get into a small space when you're in this big metal tank. So looking at the car can be very helpful. So a minute ago, I was talking about glaucoma, and that's so important to talk about in this conversation because the research is very interesting. It actually suggests that there are 2 other medical conditions that influence driving ability even more than mild dementia. The first one is type 2 diabetes because of the fluctuations in blood sugar, and that people, if you're having a low blood sugar moment, you are not thinking clearly and your vision can get kind of funny and your ability to take in complex scenery and pay attention goes down. But also peripheral neuropathy, which is nerve damage to the smallest blood vessels in the body, which in this case, we're talking about what's in the feet. Can the person actually feel between their foot and the shoe and the brake and the gas pedal, the pressure that is needed to actually safely operate the vehicle? And then of course, vision is huge. And this is a sneak peek to one of my secret weapons is those limitations are often much more acceptable to people with dementia if they don't appreciate that they have a memory problem or their visuospatial functioning is off. Oftentimes you can come back to the vision problem, come back to the reaction time problem, and in my experience, that makes for a smoother conversation. Now, in a perfect world, the person with dementia would safely transition from being a driver to being a passenger on their own accord. But unfortunately, this does not often happen. So this leaves us, after being good observers, noticing what's going on, how is it that we can actually bring this up to the person without them getting really mad at us, without us hurting their feelings, without it backfiring? The goal is to reduce risk. That is the most important thing. So we're going to talk now about some recommendations to help this conversation go better. After doing some observing and kind of getting some data, I want you to pick the right time. You would be amazed to learn how many people try to have very important, sensitive conversations at the wrong time. You cannot be tired. You cannot be hungry. You cannot be driving. Don't be thinking in your mind that you're concerned and now all of a sudden you're out on a 4-lane highway and someone swerves and this is when you decide that you need to have the big conversation that they shouldn't be driving. No, 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 no. Recognize this is an emotionally loaded conversation. It's stressful for you. It's stressful for them. You have to find a pattern of concern. Coming with one bit of evidence, one example is not going to be helpful. What I really want you to look for are multiple incidents, not isolated incidents, so you actually have a case, okay? And the thing that's most important to me is that you convey compassion and respect for how serious this is and what an emotional topic that this may be for the person. I want you to emphasize that you want to keep them independent. You have their best interest at heart, but you also have a very big responsibility, which is to keep them safe. And what it really means to love them is to sometimes have difficult conversations that are in their best interest. I wouldn't be as good of a daughter as you raised me to be if I did not tell you that I was worried, okay? The next thing is I want you to do your research before you have this conversation. Listening to me tonight is an awesome start, but what I want to do is actually link when I'm done a really, really good periodical that came out by the Hartford Insurance Financial Services Group. It came out of a pairing that they did with the MIT, Massachusetts Institute of Technology Age Lab. And what they did is they developed this really great guide called We Need to Talk. And the whole idea is how do we facilitate this conversation about safety? And so they've got warning signs, and it can be really, really helpful because you can kind of use that as your guide in having this conversation. One thing you can think about doing is talking to a trusted medical professional before you talk to this person. That can really help if you have a willing sensitive provider can take you out of the role of bad guy, because you have enough stress in everything else that's going on with trying to take good care of this person than becoming someone who gets labeled as bossy or doing things to take away their freedoms. Okay, so if you can get a good doctor on board with you, you can kind of tag team, you can bring the person in, they can have the conversation, and you can kind of sit back and get to be in your appropriate role as a spouse without having to kind of take the hit from the person directly. We need to talk about what is the actual gold standard for evaluating driving. As you all know, I am a neuropsychologist, and a lot of what I do is cognitive testing. Now, the cognitive testing, I'm on here all the time singing its praises, and it really is so powerful and sensitive of a way to understand brain functioning. But the truth is, of course, it's not real life in my little testing suites, and we struggle to match up our test findings with the real world. And this is actually an area of brain science called ecological validity. And what that means is how relevant is our task that we do in our office to you in the real world. Now, what we do with the testing has definitely been shown to be fairly predictive of how people do in the real world, but it's not a perfect science. And the gold standard approach is an on-road driving evaluation. So I want to tell you all about that. This is very, very helpful for two reasons. The first one is this is actually telling you how someone operates behind the wheel, right? So what I would recommend is finding a service locally where the person will actually come to your home. So the person with maybe mild dementia can use their own car, so there's familiarity there. And basically what they're gonna do is ask the person to take them for a drive. They're gonna be observed. They're gonna do some brief cognitive testing. They're gonna do some brief road safety questions. There's going to be a lot of stopping and starting and switching lanes and go to this familiar place and how do you get home. And then the person's going to write up a very detailed report and basically come to a conclusion that when you work with someone who's DMV certified, Department of Motor Vehicles certified, that is a standard document that you can bring and say, okay, I cannot have a license anymore. I can have my license and it's unrestricted. But in the middle is a whole spectrum of restricted license. And I think so many times people don't get this. And the fear is that it's either or. So restrictions on license can include anything from only being able to drive during the day, not being able to go on the interstate, having to stay under 45 miles per hour, only being able to go to church, only being able to go to the grocery store. There's all sorts of things that can happen in between driving and not driving, okay? So you can look in your community and see who does driving evaluations. The other thing that makes this a very smart idea, maybe just to backpedal 1 second, is that it's objective, and again, it comes out of the realm of opinion. So it's no longer you as a caregiver saying I'm worried. It's someone who doesn't have a dog in the fight who's saying this is how you performed on the driving test, right? So it makes it a little bit less personal. The other thing that is of concern that we need to talk to you about is if someone is diagnosed with mild dementia, right? And there is a pretty significant car accident. What often happens is that people's medical records are subpoenaed because they want to make sure, were they on any medication that day that might have affected them? Have they been diagnosed with a seizure disorder? Did they have a seizure behind the wheel? And what I worry about is in cases where fault is not clear, that the person who has a documented diagnosis of even mild dementia is going to be held more liable because of that diagnosis, because we still have so many stereotypes about what mild dementia means. So this is how I can often convince people to do it, is just to say, this is almost like an insurance policy, because this person who is trained and certified can come to the conclusion at the end of this, you are safe to drive. If something happens and there's a car accident, you whip out that documentation and you say, look, on this date, I was told that I was safe to drive. And that is protection for you, because in the case of bad accidents, I mean, not to scare you, but people can get their homes taken away. I mean, things can go very, very wrong. So that is very, very important that you know that you have that resource available to you. So in this conversation, it seems to me that we kind of have two pathways. We kind of have the person who has awareness about what's going on and they agree that they are also concerned. But over here we have no insight. I don't see it that way. You're wrong. I'm perfectly safe to drive, and there's resistance. So depending on which way you're going to fall is going to determine where you go from here. So let's just say you have the insight and awareness piece, okay? So this is where the active collaboration comes in. And of course, this is what we all want, but it's not always possible. This is the, you know, I've been watching Dad and I have some concerns, and what I think would really be best is maybe if you just scaled down a little bit, and you know, when you need to go up to Raleigh, that you ask me for a ride. You know, anytime you're out in the car with the person, you know, they're your co-pilot. Hey Dad, how do I get to this place? Just really making sure that you're still talking about driving, you're including them in questions about travel, how to get from here to there, and you really make them feel included in the experience of driving, okay? With the no insight and resistance, this is where the creative problem solving behind the scenes has to happen. And this is the, I don't know why the truck won't work. This is the, I can't find the keys. This is the, it needs to be fixed, it's in the shop. This is the, we had to sell it because we couldn't afford the insurance anymore. There's all sorts of things that people might need to do in order to safely reduce the level of risk, which may mean just getting the car out of the driveway, because when people see it, it's that reminder. And you know, one thing folks with dementia can sometimes do is they can get stuck on things. And if the car is there, and they've gotten in that car for 60 years, it's not unexpected that someone is then going to get stuck and over again bring up the concept of driving. So I think what we really have to recognize, though, we kind of have to have an agreement, even if the person we're talking to doesn't know we're in an agreement, which is that we really have to respect that this conversation about driving is threatening. It potentially means someone is losing identity. They can become more socially isolated in rural environments because they can't get places to and from. So talking about respecting the loss and appreciating that this may just be one loss in a series of losses for this person, really understanding the emotional and the identity piece, I think is absolutely critical. And when I try to do that and the person just doesn't understand what's happening, I often turn to these two secret weapons that I was talking about at first. The first one is what I call take the brain out of it. Once I realize the person just literally cannot comprehend that I'm saying, I'm worried you're gonna get lost, you've gotten lost, you've had 2 car accidents, and they just insist that they're safe. I've been driving for 65 years, give me a break, I'm gonna keep driving. I take the brain out of it and I go to other things like vision. I go to reaction time. For some reason, that is more digestible to people than saying that I'm taking away driving because of a brain thing. And this probably gets back to so much stigma that is still associated with dementia. But there's something there, I'm telling you, if you can't get in through one door, you got to try another, okay? The second secret weapon is something called the legacy conversation, and I've had a lot of success with this, and this is how we are going to wrap up our talk together tonight. So the legacy conversation is basically reviewing with someone what they have done in their life, all the amazing things. You know, it's so impressive to me that you were a high school football coach for 35 years and you brought the team to the championship game 10 times. That's so impressive to me. And I bet people in the community are really going to remember you for that. I can almost imagine, like, you know, when your time comes and people are writing your obituary, there's going to be so many impressive things in there about what you've done for other people and everything that you've accomplished. What I'm worried about is if we don't reduce your driving, that you could have another legacy. And it would really be awful to see all those things that you've worked for so hard throughout your life be tarnished by a terrible story like Mr. Joe Smith hit a family of 4 in a minivan and there were 3 fatalities. Now I know this is kind of extreme and it's kind of dramatic, but the truth is what we're really talking about here is life and death. If you knew that somebody was unsafe to drive and you didn't really try to do something about it and they had an accident and they killed someone, you have to live with that, and that is very painful. So you need to use motivations like that inside yourself to sometimes bump up the intensity of the conversation, really emphasizing the threat level to kind of get people's attention. So if you can talk about everything you've worked so hard for, your family's legacy, you don't want your last name to be associated with some kind of a tragedy on the road. That would really be such a shame. And there's something about that, the pride, the identity piece, that especially men, for some reason, I think just kind of click with it. And it's almost like I feel like I can land my point and they finally get it. So if you're able to have that kind of conversation and it goes well, you want to strike while the iron's hot and basically make decisions right then and there about what are the new rules of driving. And oftentimes limiting access to the vehicle is a necessity because the person might not remember what you talked about. They might have a hard time inhibiting their impulses if they want to go out for a drive. So that takes a lot of problem solving. What's most important to me that you got from this conversation tonight is that it's so important to increase the respect level when we have conversations with people with dementia. So often there is an objectification process that happens and we start talking at and to people with dementia and forget that, of course, they are still vibrant, beautiful human beings underneath a brain disease that deserve the back and forth of a reciprocal, respectful conversation. If this feels like it was helpful to you, I would love for you to like it and share it with other people. I would love for you to tell me if you've been in this situation, what has worked for you and your family. These are hard conversations, but I think it's really an opportunity for us to do better in terms of how we treat people with dementia. I'm going to be back next Wednesday and I'm going to be talking about self-care for the caregiver. We're kind of doing a little dementia trio here. So we're talking about dementia and driving, self-care for the caregiver. We talked about Lewy body dementia 2 weeks ago, and it's definitely one of my favorite topics and really something that we should all be talking about because it's not just something that affects older folks. This is going to be all of us if we are lucky enough to live that long. Thank you guys so much for being with me tonight, and I really appreciate it. I hope you have a great night. Bye-bye.